This is the last talk of the session. That is by Dr. LAKSHMI Parvati, and she'll be talking on association between severity of diabetic retinopathy and urine albumin creatinine ratio in type 2 diabetic mellitus.
UPS 6 minutes. UPS 6 minutes last.
Slide show naaki teru. Slide show naaki. Good afternoon. My topic of presentation is association between severity of diabetic and urine albumin creatinine ratio in type 2 diabetes mellitus. The prevalence of diabetes in India is 101 million, and type 2 diabetes form more than 90% of the total cases. Macrovascular complications may develop in 30% of the cases in type 2 diabetes. Generally, patients with diabetic receive medical attention earlier than those with diabetic kidney disease. DKD is now the leading cause of end-stage renal disease worldwide and causes significant morbidity and mortality. Even though KSOS guidelines suggest that the renal biopsy is an acceptable diagnostic test for managing renal diseases, performing it for the early diagnosis of asymptomatic DKD is impractical. In clinical practice, urinalysis for albumin creatinine ratio is the usual method for diagnosing early stage renal involvement. Studies have reported that diagnosis of one microvascular complication indicates a high likelihood of developing others. However, only a few studies have investigated the association between severity of diabetic and ACR in patients with type 2 diabetes. So, this aspect is explored in my study. So, my research question is an association between severity of diabetic and urine albumin creatinine ratio in type 2 diabetic patients? Objective of my study was to determine the association between severity of diabetic and urine albumin creatinine ratio in type 2 diabetic patients. So it's an observational cross-section study conducted in the Department of Ophthalmology of our institution from 4/11/22 for a period of 12 months from the date of ethical committee clearance. Study population included all type 2 diabetic patients with diabetic who attended the Department of Ophthalmology of our institution during the study period. Sample size was calculated by the formula Z square PQ by D square with a margin of error 20% based on a study conducted by Saini et al. In 2019 at Rajasthan. Sample size was calculated as 178, which is rounded to 180. So, based on the inclusion and exclusion criteria, 180 participants were recruited from the study population. Inclusion criteria was all type 2 diabetic patients above 40 years of age with retinopathy who belonged to study population and who had given valid informed consent for the study. Exclusion criteria was those with pre-existing pathologies causing media opacities that obscure the fundus view, patients with macular edema from causes other than diabetes, and patients who received an intravenous injection. So, from every participant, detailed medical and ocular history were collected, BCV and IOP were recorded, slit lamp examination of the anterior segment and fundus examination using indirect ophthalmoscope and 90D lens was done, and severity of diabetic was created by ETDR's classification. Relevant investigations and urinalysis was done for albuminuria and UACR, and diabetic kidney disease was classified as per the KSOS guidelines. KSOS category A1, that is UACR less than 30 mg per gram, A2 between 30 to 300 mg per gram, and A3 more than 300 mg per gram. This collected data were recorded under Microsoft Excel spreadsheet and analyzed using SPSS version 23. Association between severity of diabetic and UACR was determined by chi-square test or Fisher exact test, and the level of statistical significance was set up at a p-value of less than 0.05. Coming to observation, majority of the participants belong to 6th decade, that is 43.9%. Majority of the participants were males, 54.4%. Majority of the participants present with blurred vision as their presenting symptom. Majority had diabetes for a period of 10 to 19 years. And all participants were taking either insulin or OHA for their treatment, and 40% were taking both insulin and OHA. Majority had hypertension as a commonest comorbidity followed by dyslipidemia. Hematological examination revealed anemia in 43.3% of the cases. HbA1c was highly elevated in 64.4% of the participants. Elevated blood urea and serum creatinine was seen in 26.1%. And albuminuria was seen in 77 participants. Abnormal UACR was seen in 81.1%. Coming to ophthalmic examination finding, best corrected visual acuity was affected to a variable degree in both eyes. Majority had visual acuity in the range of 66 to 680. IOP was normal in all participants and NVI was present in one participant. Coming to distribution of ETDR's category of diabetic. Diabetic affected both eyes, so study participant to varying degrees, and the grade of diabetic in severely affected eye was considered for statistical analysis. Of the 180 participants, 92 had NPDR, 88 had PDR. Among NPDR, one participant had mild NPDR, 50 had moderate NPDR, 41 had severe NPDR, and 88 had PDR. 85 participants had clinically significant macular edema. The mild NPDR case was free of CSME. 38.8% moderate NPDR, 42.4% of the severe NPDR had CSME. In PDR, 16 had CSME. Coming to distribution of severity of UACR, majority belong to KDIGO category A2, that is UACR between 30 to 300 mg per gram. In this study, there was one participant with mild NPDR who belonged to KDIGO category A1. Among moderate NPDR, majority belong to KDIGO category A2, that is 46%, followed by KDIGO A1, that is 28%. In severe NPDR, majority belong to KDIGO category A2, that is 39%, followed by A3, 34.1%. Among PDR, majority belong to KDIGO category A3, 47.7%. According to Fisher exactors, there was a statistically significant association between severity of ETDRS category of diabetic and severity of UACR with a p-value 0.006. On comparing my study with the parent study, Saini et al., coming to distribution of KDIGO category A3, it was same in both PDR and severe NPDR, whereas in my study it was more in PDR compared to severe NPDR. The distribution of severity of UACR was same in both the studies, that is KDIGO A2 followed by A1, A3, then A1. To summarize, in my study, majority was NPDR. Among NPDR, majority had moderate NPDR, followed by severe NPDR, and then mild NPDR. Elevated blood urea and sudden creatinine was seen in 26.1%, but abnormal UACR was detected in 81.1%. To conclude, urine ACR is a simple useful method to detect early renal involvement in patients with retinopathy. There is statistically significant association between severity of diabetic and severity of UACR in type 2 diabetic patients. So, assessment of severity of diabetic can be used as a screening tool for early detection of asymptomatic microvascular renal complication and its progression in type 2 diabetic patients. Sir, my reference. Thank you.
Thank you. Nice presentation, doctor. But you know, you have calculated sample size. Do you know the meaning of that? Because you have given so many formulas and all. You calculated or statistician calculated for you?
With the help of formula, with the help of statistician,
You have understood the formula.
yeah, it's square p cube by that's the formula.
You have understood?
Yeah.
Sure. Okay. No questions, sir. Thank you very much. I think this completes 2 days free paper session on Dr. Subramaniam's medal. Tomorrow we'll have the finals. I hope all of you may be coming there. Thank you very much.
Thank you, Vijay sir, and thank you, Dr. Shaji. Thank you to all the speakers.